ALL, again, another rare disease, especially in adults, but it's been the benefit of a lot of advances in therapies. And I think starting with what you mentioned with minimal residual disease, at least in the United States, is probably the most important thing. It's daunting how few patients actually have MRD profiling, either due to lack of availability at the local treatment center or lack of knowledge, both in terms of how to obtain the sample. You can't obtain the sample just with it's a standard bone marrow, but it has to be the very, very first pull in a small volume setting. So it's a different approach to doing a bone marrow exam, but without MRD, which is the single most predictive and prognostic factor for AML, even more important than cytogenetics, how few patients in the United States have MRD profiling. So, and there's more data at ASH showing the importance of MRD at various stages and how that implicates survival, both in the upfront setting, but also in the relapse setting. And so I just want to make a plug that every patient with ALL who's being treated needs to have MRD assessment. It's very similar like what we do now with CML, but it really needs to be done in ALL. In terms of the therapeutic advances, everything's about CAR T cells these days, but of course many are called few answer, and CAR T cells, at least in the United States, are only approved in patients under 26, but there's lots of trials in patients over 26 looking at better CARs, if you will, less toxic CARs, demuted receptors so that you don't get a lot of the escalation of the cytokine release or neurotoxicity. And also you may get better prolonged CARs, so you don't get, T-cell exhaustion, so to speak. And so there's lots of approaches. There's also approaches looking at allogeneic CARs off the shelf, if you will. One of the Achilles heels or difficulties in getting a patient to a CAR is identifying a patient, trying to get the patient to the academic center. It may take up to 3 to 4 weeks to get the CAR made, and then you have to bridge that patient, and patients can be lost at various stages along the way. So if you had a allogeneic CAR, you can pull off the shelf and administer, and so there's several abstracts on that. And of course, most of the CARs are being employed in the B cell realm because there's appropriate targets, and in T cell disease, which is interesting because these are T cells, and if you put a CAR T cell into a patient, then you can develop fratricide where the CARs attack themselves. And so you have to genetically change that or CRISPR out the regulatory pathways that would block or blockade fratricide, if you will, so that these CARs. So having CAR T cells that can target patients with T cell ALL is also a new approach, and there are several abstracts at ASH. And then finally, the immuno realm with blinatumomab, inotuzumab, and various combinations, both in the relapse refractory setting as well as in the upfront setting in combination. So I think that we're seeing the employment of these agents, both the bispecific T-cell engager as well as inotuzumab, which is a traditional monoclonal antibody drug conjugate, being utilized earlier up front, both in older patients but also in younger patients to try and improve outcomes. So that's the themes, I believe, going forward in terms of therapy for ALL. And ASH this year really highlights all three of those foundations.